Hey, frontline nurses and trauma responders, if you've ever witnessed a patient shaking, hallucinating, and crashing fast after stopping alcohol, you've seen the chaos of delirium tremens. This isn't just a bad hangover, it's a medical emergency. Today, we'll uncover how to recognize and manage this dangerous condition before it spirals. Delirium tremens, or DTs, is the most severe and life-threatening form of alcohol withdrawal, usually occurring 48 to 96 hours after the last drink, especially in patients with chronic heavy alcohol use. Neurologically, alcohol enhances GABA, which is inhibitory, and suppresses glutamate, which is excitatory. When alcohol is abruptly stopped, GABA drops and glutamate rebounds, causing central nervous system hyperexcitability. Physiologically, this triggers dangerous autonomic instability and a hyperadrenergic state. So, signs and symptoms of DTs can escalate really fast. Early signs, which can show up within 6 to 24 hours, include anxiety, insomnia, gastrointestinal upset, and mild tremors. But when DTs set in, usually between 48 and 96 hours, you're looking at severe confusion and disorientation, visual or auditory hallucinations, profound agitation and restlessness, tachycardia, hypertension, hyperthermia, and diaphoresis, along with tremors, seizures, and even potential cardiac arrhythmias. If left untreated, DTs can lead to cardiovascular collapse and, honestly, death. Alright, so first up we need to prioritize safety and monitoring. That means initiating seizure precautions, placing the patient in a low-stimulus, quiet room, and providing one-to-one observation if their agitation is really severe. We also have to do frequent neurochecks and monitor vital signs closely. Next, let's talk about sedation and pharmacologic management. High-dose benzodiazepines are the gold standard here. Think lorazepam or diazepam. We can use either symptom-triggered or fixed-dose regimens, guided by the CIUAR scale. And if those aren't working, we might need to consider phenobarbital or dexmedetomidine for those tough, refractory cases. Moving on to fluid and electrolyte repletion, IV fluids with thiamine and multivitamins are key to preventing Wernicke's encephalopathy. We also have to correct things like hypokalemia, hypomagnesemia, and hypophosphatemia. To support autonomic function, we may need antihypertensives or cooling measures if there's hyperthermia, and we should definitely monitor ECG for any arrhythmias, and finally, always be ready to escalate care. If instability gets worse, transfer to the ICU is a must. The nursing role here is really to calm the chaos. So, keep lighting low and voices soft. Orient the patient frequently with clocks, calendars, and gentle reassurance. You want to avoid restraints unless the patient is truly a danger to themselves or others. And don't forget to involve the whole interdisciplinary team. Addiction medicine, psych, social work. Everyone plays a part. Here's the bottom line. Delirium tremens is a nursing emergency. DTs can come on fast and honestly take lives even faster. But with vigilance, sedation, and a healing environment, nurses really are the bridge between danger and stabilization. Have you managed a case of DTs? Drop your insights in the comments. We're all in this together. And hey, subscribe and follow for more critical care breakdowns, because every shift is an opportunity to save a life. And remember, sedate, stabilize, support,